Over 200,000 families in New Zealand are living in poverty. This entails a significant number of mothers, pregnant women, and women of childbearing age. Poverty can be defined as the experience of deprivation of material resources, living standards, and income. It is often measured by finding those living below the poverty line, or those having less than 60% of the median income of a country after housing costs. Poverty comprises of families having to cut back on essentials, such as fruit, veggies, and good quality meat, not being able to heat their house in the winter or having damp and mouldy housing, delaying healthcare or not being able to fill prescriptions due to cost, and having multiple people sharing bedrooms or beds within the house. Socioeconomic status or position can also be used as another indicator of poverty by considering multiple factors that influence what position individuals or groups hold within the structure of society. Ultimately, the lower the socioeconomic status of a person, the poorer their health outcomes are. And unfortunately, poverty runs in cycles, meaning children growing up in poor families in New Zealand are more likely to go on and raise their own children in poverty. Poverty is a highly complex, multifaceted issue, and the long-term implications of childhood poverty have been well documented recently through the media, governmental lobbying, and current health policy in New Zealand. Wood, McNeil, Yee, Seaver, and Rose, 2014, suggest that poverty not only affects on an individual or family unit level, but also within whole communities, by influencing access to local resources and also influencing the mindset of a community. While much of the resolutions to poverty in New Zealand are aimed at a public health and governmental policy level, this presentation will focus on the effects of poverty on an individual level. Some of the many complexities and risks associated which may arise while working with a poverty-stricken woman will be explored, focusing specifically on the antenatal period and best practice guidelines for midwives who are working with poverty-stricken women. As we know, pregnancy and early parenthood can be a trialing period of time, even for the most stable of families. But for those living in poverty, it can be a particularly testing time. The increased physical, emotional, and financial needs during pregnancy can put strain on a woman in a whānau, particularly if they're already struggling to get by. Poverty can impact on a woman and her pregnancy in a number of ways, potentially adding a myriad of complexities to the pregnancy. Identified risk factors linked to a lower socioeconomic status include increased use of tobacco, alcohol, and illicit drugs, poor diet, stressful work and living environment, delayed or reduced antenatal care, increased maternal infections, family violence, depression, increased risk of unwanted pregnancy, increased risk of teenage pregnancy, and reduced financial and social support. These poverty-associated risk factors can impact on a pregnant woman's economical, physiological, and psychological well-being, contributing to an increased risk of adverse maternal and neonatal outcomes, such as iron deficiency anemia, antenatal and postnatal depression, maternal infection, perinatal and infant mortality, low birth weight, intrauterine growth restriction, preterm birth, and SUDI. These possible implications are incredibly relevant to our midwifery practice and how we tailor-make each woman's care. There are certain demographics within New Zealand that are at increased risk of living in poverty. Families living on social welfare benefits are 6 to 7 times more likely to be living in poverty than those with at least one full-time worker in the family. Sole parent families also have significantly higher rates of poverty, as well as Māori and Pacifica families. According to Actions Against Poverty group, Māori families fare the worst, with increased rates of stillbirth, preterm birth, and neonatal mortality. They are also more likely to be smoking when pregnant and without an LMC at the time of baby's birth.
I need a dollar, 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 that's what I need. Hey, hey. Well, I need a dollar, 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 that's what I need. Hey, hey. Said I need a dollar, dollar.
Two of the most widely researched maternal issues related to poverty are poor nutrition and tobacco use during pregnancy. In particular, their association with IUGR, low birth weight, and premature birth. As the level of deprivation increases, so too does the prevalence of inadequate nutrition and smoking rates during pregnancy, and this is reflected in the increased rates of adverse outcomes on neonates. High rates of food insecurity and low vegetable intake are closely associated with low socioeconomic status. Poor nutrition and lack of micronutrients during pregnancy has been linked to adverse outcomes such as maternal iron deficiency anemia, maternal infection, premature birth, IUGR, low birth weight, and childhood cognitive impairment or delay. Iron deficiency anemia is the most common deficiency worldwide, leaving women and babies at increased risk of a number of issues. Low socioeconomic status and poor diet are both known risk factors for iron deficiency anemia in New Zealand. And while dietary advice is always recommended, for those living in poverty, good quality iron-rich foods such as red meat may not always be financially feasible, and supplementation may be required. The Ministry of Health, 2008, recommends screening iron status early in pregnancy for any women who are at increased risk of iron deficiency anemia. Current best practice guidelines for Auckland District Health Board, 2014, suggest that all women should be screened for hemoglobin and ferritin levels at booking, and supplementation is recommended as per the pathway guidelines if ferritin levels are low. A French study investigated demographic inequalities associated with dietary supplementation and found that those who used micronutrient supplementation, such as iron and folic acid, during pregnancy were slightly older with a higher socioeconomic status. They concluded that the extra cost of purchasing supplementation was the main barrier to using it, as well as the fact that those with lower socioeconomic status were less likely to be visiting their physician regularly. There are aspects of this study which may not be as relevant to the New Zealand context, as women here are offered fully subsidised prescriptions during pregnancy. However, the 2008 Living Standards Survey found that 10% of poorer households were still unable to fill prescriptions due to lack of funds or more immediate costs such as rent or food payments. It is important to screen ferritin levels of all women at booking, more importantly those living in poverty, and follow local policies and guidelines for pathways for iron supplementation. Prescribing fully subsidised options to minimise the cost to the woman would also be best practice. Poverty-related inadequate nutrition and poor weight gain in pregnancy is associated with low birth weight and IUGR. However, much of the research into this looks into poverty-stricken women in developing countries, for example India. It is important to note that inadequate nutrition is not always reflected by poor weight gain. In the New Zealand context, poor nutrition may not be insufficient calories, but more importantly, insufficient vitamins, minerals, and nutrients. The Ministry of Health, 2008, found that low-income households are more likely to have insufficient fruit, vegetable, and red meat intake, and a high fat intake. Highly processed carbohydrate and trans fat-rich foods are vitamin and mineral lacking and often significantly cheaper. These are often the base diet for low socioeconomic groups, and these types of foods contribute to the global obesity pandemic we are seeing. Sachs, Hall, McPherson, Finegood, Moody, and Gortmaker, 2011, found that for high-income countries, obesity rates are disproportionately higher for disadvantaged groups. This mirrors the current statistics in New Zealand, where the Social Policy Evaluation and Research Unit 2015 found the incidence of obesity was up to 1.6 times greater for those living in socially deprived areas compared to those in the least deprived areas. Maternal obesity is associated with intrauterine death and IUGR, meaning in our New Zealand context, poor weight gain may not be the main indication for inadequate nutrition and the risks associated to pregnancy. Nevertheless, with regards to nutrition, education is key. Poverty-stricken women may have a minuscule amount of money to spend on food each week and many mouths to feed, and in reality, healthy food is more expensive than unhealthy food. Approaching healthy eating and exercise in a non-judgmental manner where the woman feels supported and not belittled is key. Working in partnership with her to share information on healthy eating during pregnancy using the Ministry of Health's guidelines. It may also be helpful to refer the woman to a nutritionist or dietitian should you feel that further expertise is needed. However, there may also be barriers such as travel costs which prevent her from attending additional appointments. There are often community initiatives for healthy eating and exercise, and this may be a fun alternative and a different way of sharing information. For example, Nestle is currently funding the startup of a free initiative in South Auckland called Cook for Life, where information is shared about nutrition and hands-on experiences gained by preparing healthy and tasty meals. According to the Ministry of Health, 2009, rates of smoking during pregnancy increase as socioeconomic status decreases, particularly for women of Māori descent, where 43.5% of Māori women are smoking at the beginning of pregnancy. Evidence suggests there is a link between smoking and stress, and people of lower socioeconomic status are thought to have more stressful home and work environments, with possible insecure employment or unemployment. Thus, it is proposed that they use smoking as a way to cope with stress. Many pregnant women feel smoking helps them deal with their stress, or gives them a chance to break free from it. It is a requirement for us to screen all women for their smoking status, and at the same time we can screen the household and partner. If currently smoking, the Ministry of Health, 2009, recommends following the ABC approach as the best practice framework to provide support to quit. The ABC approach is as follows. A. Ask the woman her smoking status and document. B. Provide brief advice to stop smoking, despite whether she wants to quit or not. The scope study suggests that this could be a chance to have a positive conversation around the benefits of quitting before 15 weeks, rather than focusing on the negatives. C. Cessation service. Make an offer to refer to a cessation service. Some DHBs, for example Counties Manukau, offer a rewards-based program, so it is worth having up-to-date knowledge of what current initiatives are in your area. As part of C, a midwife is also able to offer nicotine replacement therapy and prescribe this to a woman and her partner while awaiting referral to the quit service. Estonk, Glover, Kira and WageMakes 2014 stress the importance of cultural safety when working with Māori women who smoke. They mention the importance of supporting the woman in a Māori way and involving her whānau. Being yourself and connecting, engaging, and forming a relationship with the pregnant woman. They also noted that it was beneficial to stay in contact with the woman, particularly if there were members of the whānau who continued to smoke. Monitoring fetal growth is also important due to the risk of IUGR, and this should be done using a customized growth chart and referring as per the referral guidelines if indicated. While poverty-related IUGR, low birth weight, and preterm birth was initially thought to be predominantly linked to modifiable determinants such as smoking, nutrition, infection, and high alcohol or drug consumption, discrepancies between observational and randomized controlled trials questioned this. The studies looked into the effects of early antenatal care with advice around smoking and nutrition, and how that improved pregnancy outcomes in relation to preterm birth and IUGR. The observational studies saw an improvement in outcomes, yet the randomized controlled trials did not. The theory that antenatal care does not improve outcomes contradicts all current health policies on improving poverty outcomes in New Zealand, where they stress that early engagement into maternity care is imperative. Nevertheless, these discrepancies prompted further research into the underlying psychological differences between women who choose to initiate an antenatal care and those who do not. Chronic psychosocial stress is now gaining acknowledgement as a leading factor through which poverty has a negative effect on pregnancy. Researchers found that maternal stress during pregnancy has been linked with preterm labour, low birth weight, IUGR, preeclampsia, intrauterine death, immune suppression, newborn infection, adverse physical and mental outcomes. Wadsworth and Rinks, 2012, state that the stress of poverty is not just financial worries. It creates a context of stress in which food insecurity, conflict, family violence, addiction, and frequent change in residential location are common. Lack of social support, poor quality of life, unemployment, and marriage status significantly alter perceived stress levels. Chronic stress alters the body's normal stress response and reduces the ability to deal with additional challenges. This can cause a physiological response in the body by triggering a number of hormonal pathways and ultimately leading to preterm birth. According to Kahn and Perlin, as cited in Wadsworth and Rinks, 2012, among the array of chronic stresses that people may confront in their daily lives, there is probably none more pivotal than economic hardships and strains. Additionally, poverty-related maternal stress also influences self-esteem and predisposes women to depression during and after pregnancy. It can also result in a lack of investment in the pregnancy. Hine et al. 2013 suggests that partnership status has the strongest effect on depression, and that sole mothers are at increased risk and should have early intervention to provide support. It is important to look for signs of depression throughout the entire pregnancy and refer to maternal mental health service or the woman's GP if concerns arise. Stressful living conditions and low self-esteem can increase the risk of adverse behaviors such as smoking, drug use, and lack of engagement in antenatal care. According to Meng, Thompson, and Hall, 2013, negative feelings towards themselves or the pregnancy can leave a woman having low commitment to the pregnancy, and they are at greater risk of disengaging, meaning we as midwives need to be more supportive than ever. Many women living in poverty will also not engage in antenatal care, will present late, or will miss appointments due to financial barriers such as travel costs or lack of childcare. If you are caring for a woman who is not engaging in care, it is worth reviewing possible reasons. If there are financial barriers, it may help to offer home visits for antenatal appointments, where travel barriers are excluded. Limit costs to her, such as informing her of free antenatal classes, and choosing lower cost radiology services for ultrasound scans. It would also be of benefit to have current information on subsidies or benefits that she is entitled to, and an early referral to a social worker would provide help from someone who is more specialized in this area. I hope that it has become apparent that poverty is not a single complexity, but involves many layers of interweaving complexities. While as the woman's midwife, we can't provide an immediate fix, there are ways in which we can work with her to provide a supportive, caring, and educational environment where we hope to reduce stresses and minimize any adverse effects on her pregnancy and baby. Unfortunately, there are no current guidelines in New Zealand specifically looking into poverty-stricken women during pregnancy. However, the NICE guideline, Pregnancy and Complex Social Factors, 2010, includes poverty as a factor. Women-centered care is at the forefront of these guidelines and is in line with our midwifery philosophies and practice standards here in New Zealand, where partnership, cultural safety, communication, and information sharing is imperative. Due to the multifaceted nature of poverty and its related complexities, a multi-agency approach is best practice according to NICE. The following slide is a summary of best practice guidelines for working with poverty-stricken women, which I have compiled from research articles, health policies, practice standards, and other guidelines.
Dollar, that's what I need. Hey, hey. Well, I need a dollar, that's what I need. Hey, hey. Said I need a dollar, that's what I need. And if I share with you my story, would you share your dollar with me? Bad times are coming and I reap what I done sowed. Hey, hey. Well, let me tell you something, all that glitters ain't gold. Hey, hey. It's been a long old troublesome road, and I'm looking for somebody come and help me carry this load. I need a dollar, that's what I need. Hey, hey. Well, I need a dollar, that's what I need. Well, I don't know if I'm walking on solid ground, 'cause everything around me is falling down. And all I want is someone to help me. I had a job.